Good afternoon, everybody. I'm Ron Ackerman. I am the director for the Institute for Public Health and Medicine, and I want to welcome you to today's IPHAM webinar seminar. We're using a hybrid format again today, as we have the last few weeks. I think that's been working really well, which means that we have participants online through Zoom as well as in the room here today. If you are on the Zoom, please feel free at any point to enter questions that you might have of our presenter, but do use the Q&A function on your ribbon of your Zoom screen. We don't monitor the chat for questions. We might put some announcements in there, but if you have a question, just put it in the Q&A and we'll come back to that at the end of today's presentation. From you all in the room, we'll invite questions and answers the old-fashioned way. Just raise your hand, and I'm sure Dr. Allen would be happy to entertain those. So the speaker today is a pleasure to announce. Dr. Norrie Allen is Associate Professor of Preventive Medicine and the Quentin Young Professor for Health Policy in the Department of Preventive Medicine here at Northwestern University Feinberg School of Medicine. She is a wonderful epidemiologist and colleague who runs a variety of large studies and is here today to talk to us about cardiovascular health in childhood, which is an area of her own personal expertise. So with that, I'd like to welcome Dr. Allen to the podium to present to today's IPHAM seminar. Thank you.
Hey everyone, I'm glad you could make it either in person or virtually, and I appreciate the kind comments introduction. So I'm going to say there's an advantage to being in person. Feel free to interrupt me if you have questions along the way. So in addition to food, that's another advantage. And I hope this will be a conversation about where we are with cardiovascular health in childhood. Okay, so I want to give you a quick roadmap of where we're going to go today. So I'm going to talk about what is cardiovascular health. Many of you may have heard this, but I hope I can show you that there's an update. So we have a new definition of what cardiovascular health is. I'm going to talk a little bit about cardiovascular health in children across the US, and also think about how cardiovascular health changes over childhood and into adulthood. I want to end kind of looking at what's driving those trends in cardiovascular health in childhood and steps that we can pursue that may promote cardiovascular health throughout the life course. And last, I'm going to give kind of a little plug about a study that we're working on right now called the Young Heart Study. Just as a mention, my disclosure, so I'm funded by NIH and AHA, and I work as a scientific advisor for AHA unpaid. So we've been looking at cardiovascular health and the drivers of cardiovascular health for decades. For a long time, we've known that the major risk factors for cardiovascular disease are these top risk factors shown here in red, and they are the largest drivers of adult cardiovascular disease. And importantly, they make up a vast majority of all cardiovascular events, so that over 80% of all cardiovascular events are really preventable given these modifiable risk factors. That work has led to a number of publications combining those risk factors into a global cardiovascular health score. So what do we mean by cardiovascular health? Well, those risk factors I just showed you that are both modifiable and the leading causes of cardiovascular disease are highly interrelated, and cumulative burden of those risk factors is really important to predicting events. So we define cardiovascular health now using Life's Essential 8. So this was recently released just this summer, actually. And Life's Essential 8 is a construct that was created by the American Heart Association at the beginning 10 years ago and updated this past summer. And it essentially creates a global score of cardiovascular risk, now including 8 risk factors, 4 health behaviors, and 4 health factors. So those 8 are smoking, sleep, which I'll talk about in detail because that's the new one, a healthy diet and physical activity, and then 4 health factors: blood pressure, lipids, blood sugar, diabetes, and a healthy weight. So I mentioned that this was a recent update. So in July, I believe it was, we redefined cardiovascular health using these 8 metrics. Cardiovascular health was first kind of conceptualized and defined in 2010 as Life Simple 7. And this summer, we added a number of changes that we think will be very advantageous for measuring, monitoring, and modifying cardiovascular health across the life course. So obviously, the most essential one, or the most major one that people have identified, is that we've added an additional metric. So I now have a fancy new pin, larger and better, I guess, than the 7s. It doesn't go upside down. And we now have added the 8th metric of sleep. Sleep was added because it was recognized that in the past 10 to 12 years, there's been a growing literature demonstrating sleep as an independent risk factor for cardiovascular disease that's able to be measured and modified. In addition to adding sleep, we made a number of additional updates as well. So the traditional cardiovascular health score from the last decade was measured 0 through 14. There were ideal, intermediate, and poor levels of each of the 7 metrics, and those were added up to a full score. 0 to 14 left a lot of room for changes that didn't influence the score. So for example, if you had a intermediate physical activity, that was somewhere between 1 and 140 minutes of moderate or vigorous activity a week. If you made an improvement in your lifestyle and behavior and you started exercising, if you did move from 1 minute a week to 149 minutes a week, it didn't improve your cardiovascular health score. So in order to promote the advantages of making lifestyle changes and improvements, we wanted to give a finer grain to how we define cardiovascular health. And it is now a 0 to 100 score, which is very kind of understandable and interpretable for each of the metrics. It's also more sensitive to inter-individual and intra-individual changes over time. So that example of if you make an improvement in your behavior or lifestyle, we want it to count towards improvements in your cardiovascular health. And it also is promoting the assessment of cardiovascular health, both in clinical practice, in communities, in order to better target interventions to cardiovascular health. And I think the last thing I want to highlight is we made an important step forward in understanding the critical importance of social determinants of health as really the foundation of cardiovascular health. So as I mentioned, sleep is the new metric. It's defined right now as duration, the number of hours, average hours of sleep a person gets per night. This is the adult definition. In childhood, that includes naps and other sleep times as well. So each of the metrics is tailored to the age of the individual as well. And sleep was important because, as I said, it's been associated with cardiovascular disease and cardiovascular health, and it's also relatively easy to measure and something that we've done in a lot of our cohorts and NHANES as well. So we have the ability to actually measure it and modify it in the population. Again, the health behaviors are not smoking or vaping. Vaping was added as well to the smoking criteria, getting adequate sleep, having a healthy diet, and we operationalize that so it was easier for research studies and clinicians to assess a healthy diet, and getting physical activity, adequate levels of physical activity. And then the health factors are blood pressure, blood lipids, a healthy weight, and using BMI and blood sugar. So you can see now that each new metric is 0 to 100, giving you a nice kind of sliding scale as to where you are. The higher, meaning the more ideal cardiovascular health score. And cardiovascular health is really the core of cardiovascular health is that it is more than the sum of its parts. That if you just looked at each individual risk factor, you would get less information than if you look at the global cardiovascular health score, which is giving you a global summary of their health. So each of the 8 metrics are calculated using the scales at the end from 0 to 100. Then the average of those is their cardiovascular health score. So I want to make sure you're oriented to that as we move forward. In order to kind of compare prior literature, we then also define the 0 to 100 and break it down into categories of low, moderate, and high CVH for comparison with the prior Life Simple 7. What I want to draw your attention to here is that we understand and appreciate that life's essential aid is really at the core of the social determinants of health that are foundational to an individual person's ability to achieve and change their individual measures. And it's also interrelated with their psychological health, with one being intimately tied to the other. And so while psychological well-being are not part of the core constructs of the life's essential 8, we understand the interrelationship, and without changing one, we can't change the other. So just as a reason, why do we care about cardiovascular health? Well, there's been a lot of studies. This is just one of many. There, I think, numbering in the thousands at this point, that has looked at the long-term impact of cardiovascular health on events. So if you look at cardiovascular health in middle age, you see that there's a 2 times greater lifetime risk for cardiovascular disease for people who have low cardiovascular health as opposed to ideal cardiovascular health. So it's strikingly, very strongly related, I should say, to cardiovascular events later in life, up to 40, 50 years later in life. And importantly, we have done projections looking at the impact of if we could shift the population from intermediate to ideal and from poor to intermediate, how would we reduce the burden of cardiovascular disease in the United States? And so this was just one example, but basically it shows you that, if we shifted the proportion of adults to just about 55% of the population was in ideal cardiovascular health, we could prevent over 1 million cardiovascular events per year. So shifting cardiovascular health, even a small amount, has major impact on our cardiovascular events. And this is just a small snippet of the literature that has demonstrated the link between cardiovascular health and outcomes. I showed you primarily cardiovascular outcomes, but the very interesting thing about cardiovascular health is that it is impacting a wide variety of outcomes, from cardiovascular disease and mortality through cancer, renal disease, cognition, stroke, dementia, depression, quality of life, and general well-being, healthcare costs. So its impact is very wide and very broad. Understanding the cardiovascular health pattern is really critical, because we know that prevalent risk factors in middle age has a strong relationship with events later in life. But reducing risk in middle age does not restore their lowest risk had we prevented the loss of ideal cardiovascular health in the first place. And so much of the work that I'm going to talk about right now is thinking about this paradigm shift to what we call primordial prevention. So primordial prevention is really preventing the development of risk factors, or the loss of ideal levels of each of those 8 metrics, and maintaining ideal cardiovascular health throughout the life course, instead of trying to address elevated levels or poor cardiovascular health factors. So just quickly, this is a huge slide, and I want to draw your attention directly to the most important parts. So when we redefined cardiovascular health as life's essential 8, we wanted to look in the population of children and adults to identify where are we at now, and what are the interventions that we can do that can change that and improve our cardiovascular health in the US. So these are the NHANES metrics. We have used them as our kind of monitoring system for how we're doing in cardiovascular health. At the top, you can see this is overall cardiovascular health. So it's a sum of up to 8 metrics, and I'll talk about that in a minute, across different ages from 2 to 19, where we consistently have 3 metrics across the age range, up through 16 to 19, where we have all 8 metrics. So the interesting thing is that in NHANES, we are missing some of the clinical factors, the health factors at the youngest ages. What is driving this cardiovascular health in preschoolers and early childhood is predominantly the health behaviors, which we have measured. What I think is particularly interesting and sobering is the fact that when we look at young ages, either 2 to 19 or 6 to 19, you can see that we're already at a population level in intermediate cardiovascular health. So we're not starting off at ideal levels, even at those young ages. which means if we're thinking about primordial prevention and preventing the loss of ideal levels, we have to go very early in childhood for a vast majority of children. And there's obvious differences. I'm not going to focus on them right now, but there's differences in gender and race and cardiovascular health risk as well. The metric that seems to have the worst cardiovascular health score is diet, not just in children, actually, across the US population. When we looked at what proportion of the US population has an ideal diet in the old metrics, it was almost 0%. It was impossible to find anyone. And that's a really hard metric to meet. We can see already that even for children 2 to 19, that they have an average cardiovascular health score for the diet metric of 42. Which means they're not adhering to a healthy Mediterranean style diet. And there's a lot of room for improvement. We're doing better, but not perfect at all by looking at nicotine exposure. For children, nicotine exposure is included in secondhand smoke. For adolescents, as shown here from 12 to 19, it not only includes traditional cigarette nicotine exposure, but also vaping, which is sadly growing more prevalent in this population. I'll run through this quickly, but you can see there's a large room for improvement, both in physical activity and sleep as well, so that we're already kind of in this moderate range. With variability, I think the important one to look at is, unfortunately, as children age, here on the bottom here, right here, you can see that the proportion who meet the physical activity guidelines decreases in adolescence. We are doing better in terms of blood glucose and BMI, and the clinical measures tend to be kind of subsequent to the loss of the health behaviors that we see early in life, in childhood. And lastly, this is the metrics for blood lipids and for blood pressure, that are in older childhood and adolescence. You can see the lipids declining here with age as well. So that's kind of where we are in a current snapshot of adolescence in the United States. What I think is important is that there's a growing amount of work that has looked at childhood cardiovascular health and adult outcomes. So this was a paper that was recently published in New England Journal of Medicine just a couple months ago, actually, which is one of the first that has actually tied childhood cardiovascular health via a Z-score. So that they could look at it across age ranges. So this is the Z-score, with a higher Z-score indicating a worse cardiovascular health, to adult events. So these cardiovascular health was measured at about age 2 to 19. So older childhood to adolescence, and they were followed for 35 years. So these are cohorts that have been long running over the past several decades, and they identified a strong relationship between childhood cardiovascular health and adult events 35 years later. That's not taking into account their adult cardiovascular health as they've aged. So already by 2 to 19 in childhood, their cardiovascular health of an individual child is strongly predictive of their future risk. So as I mentioned, instead of trying to change a child or adult's cardiovascular health, our goal right now is to try and preserve it before it's lost. So that primordial prevention concept I talked about. What we haven't known right now is what is the decline in cardiovascular health and where are the critical periods in cardiovascular health that we will have the most impact if we intervene on. I showed you some data from NHANES, but as you saw, there was a lot of missing data in terms of what the cardiovascular health factors were down into childhood, and very little, if any, from birth to 2, thinking about that. We know that we were naive in our original thinking that all children were born in ideal cardiovascular health and lost it from there. And we know that there are children that are born at risk already of losing cardiovascular health, essentially at birth. We've looked at trajectories of cardiovascular health. So up till now, we've been looking at kind of cross-sectional looks at what cardiovascular health measure is at one point in time. But we know that cardiovascular health evolves across the life course, and that period of childhood is a particularly dynamic period where people's behaviors and factors are changing due to a variety of circumstances. So this is older cohort data pooled together to look at trajectories of cardiovascular health starting at age 8, going through 55. I want to draw attention to one thing, two things actually. One, this is the old scoring system, so it's 0 to 8. So you don't see that 0 to 100. But again, higher is better. Lower numbers are worsening cardiovascular health. And two, that this score is made up of predominantly the health factors plus BMI. So this is not looking at behaviors. This is looking at the downstream consequences of those behaviors in terms of glucose, blood pressure, lipids, smoking, and BMI. So those 5 clinical measures are what's making up these trajectories. And what you can see is that already by age 8, we have significant heterogeneity, where a good proportion, about 20% of all children, are actually already intermediate risk for the clinical factors themselves by age 8. That's a large proportion of the population that at that young is already experiencing elevated clinical factors. In addition, what we see is for almost all of these trajectories, there is a decline in cardiovascular health as they age, with differences in the rate of decline or the slope by childhood groups. So you can see that there are some kids who start low, but are able to kind of maintain and see a slight decline. And there's some, this highest risk group, that start at intermediate levels, and their cardiovascular health declines rapidly and early in their adult lifetime. And that's important because it translates directly to their risk for cardiovascular disease. This is looking at a subclinical measure called carotid IMT thickness. It's a measure of subclinical atherosclerosis. And you can see that the thickening of the artery indicates a higher future risk for cardiovascular events. So that children who are intermediate and declining rapidly have the thickest arteries and at the highest subsequent risk of cardiovascular events. So not only where you start, but how your cardiovascular health changes in childhood and adolescence is critically important for future risk. So we've been doing a number of projects. I'm going to just touch on one that we are finishing up now, I guess. We have cohort data that I just showed you. We are missing some of the behavioral risk factors, and we're missing the ability to look in a current contemporary population where we know the health factors have changed over the last few decades. We have been using electronic medical records to identify cardiovascular health trajectories in a contemporary, diverse cohort of children across Chicago. Many of you may know the Capricorn network led by Dr. Ko, and it brings together the electronic medical records of many of the major healthcare institutions across the city of Chicago, and is actually linked to a network that is the PCORnet network across the country. So from Capricorn, we have over 1 million children with almost 8 million encounters, and we've been looking at their clinical cardiovascular health trajectories across age. What I can say is this is a relatively simple plot. There's fewer lines. And what you can see, though, is that at age 2, this is similar to what we found at age 8, that already by age 2, so now we're backing up into preschoolers, that there is a significant heterogeneity in baseline cardiovascular risk with almost 20%, again, 1/5, that are at a worse cardiovascular health and already at risk in preschool. And that all of those trajectory groups decline more or less rapidly throughout early and later childhood. And I'm not going to focus too much on this, but what I want to draw your attention to is what appears to be driving those changes is BMI. So the leading indicator is what we call, the leading indicator of cardiovascular health is often BMI, where we have that data available and we have the ability to measure it and monitor it throughout childhood. And that appears to be the leading indicator of worsening cardiovascular health. So you can see that the blue line is the high stable group, the most ideal cardiovascular health trajectory. And they have the lowest, more ideal BMI percentile, while the intermediate and declining group has the highest BMI percentile in childhood. And those differences that are pretty consistent across age groups appear to be driving changes in blood pressure over time, which appears to be following in that pattern. And you can see if you put these two different samples next to each other that they're amazingly consistent, especially when you're considering the fact that one is from cohort studies on the what's your right, your left, I guess, depending on who you want to talk to. This is from EHR data. So you can see that they line up fairly well, and there start to be groups that diverge and separate based on their loss of cardiovascular health when you start kind of in later childhood and early adolescence. And that's important because we want to identify when are the critical periods where intervention of promoting cardiovascular health is going to be most effective at helping individuals preserve it later into life. And so we looked at where does that slope and that loss of cardiovascular health accelerate? Where do we start? What ages do we start to see that loss accelerating in life? And one of the biggest ages actually is around age 17, 18, depending on gender, which makes sense. It kind of lines up with our stereotypical kind of freshman 15, our discussion about individuals moving out to be more independent. That may be changing over time, but moving out on their own, unfortunately, often gaining unhealthy lifestyles, and that has long-term implications for their cardiovascular health. And there's a less striking, but still statistically significant inflection point, again, at about 35, where we believe that the demands of family, of work, those stresses have added impact on cardiovascular health throughout middle age. So that gives us at least a starting point to think about where should we start intervening and how do we start creating interventions that are going to protect cardiovascular health. So I just wanted to kind of summarize all of that. I know it was kind of a whirlwind tour, but basically, we know that childhood cardiovascular health is associated in middle age with atherosclerosis. And now, critically, we know it's associated with lifetime events of cardiovascular disease. We know that there are multiple trajectory groups of cardiovascular health. Not all children are going to follow the same path in terms of developing cardiovascular risk, but almost all of them experience declining cardiovascular health, which starts as early as age 2 and accelerates as they get into adolescence. And that adolescent period appears to be a very critical period where we experience more rapid declines in cardiovascular health and where health promotion may actually have the biggest impact in reducing cardiovascular burden. So why are we seeing this? Why do we see this loss of cardiovascular health? Why do we see it start so young? And what's driving it differentially across groups? So there was an NIH working group that was looking at this, and it's I think an important figure to look at as it talks about like the different causes of cardiovascular health and the loss of cardiovascular health with age. So you see these root causes. So we're talking about going all the way back into uterine environment and thinking prenatally about the influences that drives cardiovascular health in infancy, in early childhood, and then thinking about how those root causes translate to poor health behaviors, then translate to traditional risk factors and elevated risk factors, and ultimately to subclinical atherosclerosis and events later in life. And what we're hoping to do is really square this curve where individuals can maintain the highest cardiovascular health as long as possible into and through adulthood. So we've looked at a large number of studies to identify what are the predictors of a child's cardiovascular health. And this is just one analysis, but there's been a multitude of them actually published across cohorts that suggest that one of the strongest predictors of cardiovascular health in children is their parents' cardiovascular health. This is just a long list, but that parental cardiovascular health is highly correlated with their child's cardiovascular health. And we've been very focused on understanding what is this intergenerational transfer of health? Like, how does a parent's cardiovascular health, what are the drivers of its influence on child cardiovascular health? And I'm sure you guys all have ideas as to what those might be. And ultimately, actually, there have been interesting literature seeing how that navigates down into third generation effects as well. So there's a HAPO study. I don't know if anyone knows the HAPO study. It's one of the sites here at Northwestern. It's been a great study looking at gestational diabetes throughout the years. And they assessed cardiovascular health in women who were 28 weeks gestation. So they were pregnant, and created a measure of maternal cardiovascular health during pregnancy with the child. And then they measured the offspring or the child's cardiovascular health in adolescence about 10 to 15 years later, and looked at the relationship of maternal cardiovascular health with child cardiovascular health. And what you can see is that compared to women with poor gestational cardiovascular health, those that had high or more ideal cardiovascular health during the pregnancy had children who were much more likely to have high cardiovascular health 10 to 15 years later. And that exposure of maternal cardiovascular health was strongly and significantly related to the child's cardiovascular health, even once you accounted for all of the other changes that happen in both the parent and child over the following 15 years. So pregnancy may be an additional window of opportunity and critical period where we can intervene during pregnancy and impact the lifelong cardiovascular health of the offspring, and hopefully of the mother as well. The question I often get is whether this intergenerational transfer of cardiovascular health is driven by genes. And we've done a number of studies. This is one in Framingham, which is a multi-generational cohort study looking at heritability and genetics of cardiovascular health. And what I can safely say is this is one of the few studies in which both the behavioral and the genetic epidemiologists were both happy. So the genetic epidemiologists were very excited because there's a significant portion, about 15% of heritability is due to shared genetics. What I, as a non-genetic epidemiologist, was very excited to see was that about 85% or the vast majority of heritability, of similarity between parent and child CVH is driven by shared environment. It's driven by factors that are modifiable. And to me, that's really critical, right? Because if you look around at your family and say, everyone looks like me, everyone has the same cardiovascular health, there's nothing I can do, that's a very defeating and very hard to intervene on. But if you can say, yes, everyone has shared behaviors, if we can alter them together, then we can make an impact. That's, I think, an achievable target. And that's kind of where we're going. So we've done a lot of work documenting cardiovascular health, identifying the relationship of the trajectories with outcomes, but future work is really focused on understanding the causes, what's causing those declines, in the hope that we can intervene and target the interventions to the specific populations at highest risk for decline in cardiovascular health, at the time period where they're most sensitive to losses of cardiovascular health, and with the interventions that are best targeted to those factors which are declining. With the goal of preserving cardiovascular health across the life course and squaring that curve so that we're improving the health span. Now, I apologize, it's a little bit grainy, but when we think about interventions, we have to think about tailoring to them to the life period at which we're intervening. So I called into focus the period of adolescence, about age 18. And so we talk about that in terms of college and workplace and community-based programs. And what this is focusing on is identifying key drivers of those interventions at different life periods. We're focusing here in this time window, but there's additional and different interventions that you would want to continue to promote throughout the life course. But when we think about prenatal, we talked about maternal CVH being important for childhood CVH. So we have to think about prenatal and postpartum care. And in fact, Dr. Tandon is here, but there's an enriched study that's being funded by NIH, which is looking at that, one of those exact questions about home visiting to promote cardiovascular health in mother and child. When we think about early childhood, we have to think about school-based and family-based interventions based around well-child visits, and how do we help pediatricians measure and monitor cardiovascular health, and then ultimately what tools do we give them to help impact cardiovascular health in their patients and families. And then adolescence is a particularly tricky time. Most and many kind of drop out of the healthcare system. And so I think we have to think about community and other strategies to intervene and work with adolescents. So it leaves a lot of opportunities for us to continue our work, which is there's no shortage, I think, of ways to get involved. So there are relatively few contemporary cohorts of cardiovascular health in children. We know that the population in the US is shifting dramatically, shifting in terms of its racial and ethnic makeup, shifting in terms of its behavior and lifestyle. I think COVID has accelerated some of those and shifted them as well. We have little data starting at birth and early childhood. So most of the work I've shown you, at least on the behaviors, has been focused on older childhood. And we're just, I think, starting to understand some of the metrics in infancy and preschool age kids. We don't have a lot of information about behavior and lifestyle interventions and how they impact cardiovascular health as a metric itself. Again, we want to not only shift individual factors, but because they're so interrelated, we actually need to shift the whole cardiovascular health score to more ideal levels. And then this interesting and complex issue of intergenerational transfer. When we're talking about influencing cardiovascular health in childhood, we're not talking about intervening on just the child, right? We're talking about intervening on the family. We're talking about intervening on the parents. We're talking about intervening on the child as they move into parenthood themselves. So that I think raises a whole new nuance to how do we promote cardiovascular health in this period. And I would say we're still in our early stages of understanding how do we actually define cardiovascular health very early in life. I picked the easiest ones. The clinical measures are always the easiest ones, right? We've got percentiles for BMI and blood pressure. We measure them in well-child visits. But how do we define ideal physical activity in a 6-month-old? How do we define a healthy diet in infancy? We have some ideas. We think about, unstructured play and tummy time. We think about breastfeeding or introduction of solids, but I think we're still working on finalizing those definitions so that we can use them going forward. And I think we also need to understand how diversity of context, diversity of culture impacts cardiovascular health and the interventions that we tailor to those groups. So I'm just going to end with a little bit of a plug, I guess, for a study that we're doing now, which is called the Young Heart Study. It's a pragmatic cohort. And I say that because it was launched in the era of COVID. It has no in-person visits, but it has remote data collection. And that remote collection allows people to join the study completely online on the web or on a mobile platform, their phone. Makes it easy for them to get on, to consent, to answer surveys that are brief and age relevant. And then it allows us to link to their clinical records. So we believe it'll be really critical in advancing our understanding of the full concept of cardiovascular health, because it includes not only the clinical factors, but it also includes the behavioral factors, and it also includes a lot of information about context, family, and well-being. We're recruiting right now, so we're targeting 7,000 children in the city of Chicago. The plan is to roll it out nationally because we have the ability now to link medical records via the platform as well through MyChart, and will really provide us with an understanding and a diverse cohort of children contemporary children, what cardiovascular health looks like. We'll follow each of them for 2 years to understand changes in cardiovascular health. And by knitting together across the ages, we actually can create a full cardiovascular health trajectory from infancy to age 18 for all 8 of the metrics and understand the contextual drivers of those metrics, with the goal of creating a growth curve, with the goal of creating a tool by which clinicians can measure and monitor cardiovascular health so that we can get to the next step of intervening and promoting. So just it's like I said, it's a pragmatic cohort. It pulls EHR and web-based surveys together. It takes 30 minutes. It's really easy. We've had a lot of uptake in terms of being able to sign up quickly. And it's being promoted both here at Lurie Alliance. So we recruit from clinics around the city. And like I said, not only do we get all of the 8 metrics of cardiovascular health, but we're also particularly interested in those social determinants of health and the contextual influences that we believe are really driving childhood cardiovascular health, especially early childhood. And I have a great collaborator, Dr. Mandy Perak, who's also interested in not only the child's cardiovascular health, but the mother's cardiovascular health throughout this period as well, from pregnancy into early adult childhood. And so at the end of it, it'll look prettier, I hope, at the end, but we will essentially have created an app that is able to be embedded in Epic and can be used by parents and clinicians to measure cardiovascular health. So some of these metrics, diet, physical activity, will have to remain as surveys. And then they can be calculated and plotted and tracked throughout childhood so that whenever a child, you start to see those declines, we can intervene early and quickly to promote cardiovascular health, as opposed to waiting to get kind of more clinical thresholds where we would start acting in terms of treatment. So it'll be an easy tool that's able to go there. And we've already kind of started. We have the pilot version of this that was created using NHANES and a variety of different sources, where we've not only taken the BMI percentiles and the blood pressure percentiles that have already been published and are used in clinical practice, but also built out the clinical factors for glucose and cholesterol. Some of these have changed over time. You see fairly dramatic shifts in puberty for some of these measures, but the goal is to be able to provide an easy, accessible interface to both measure and track cardiovascular health. And again, this data has only so far been done for the clinical factors. What we don't know about is all those behavioral factors, which are so critical that early in life course. And so I will just kind of end on that note and give a little plug for the fact that heart disease really starts in childhood. I think when we started moving down in this work, we thought, well, maybe we'll start at 30 or, maybe even the 20s, and we've got it there. Like everyone comes into there with ideal cardiovascular health. And I think maybe not surprisingly, we're a little shocked that cardiovascular health metrics, especially those behaviors that have been long studied, were already falling into these kind of more intermediate and poor levels very early in life. I think there's opportunities for primordial prevention starting in utero and moving out from there. No period is a lost cause, I guess I would say. So every point of intervention that we can have, it is going to be critical to being able to promote cardiovascular health throughout the lifetime, and we'll probably have to be continuing having multiple touch points in childhood, adolescence, and adulthood. But we need a deeper understanding of what are the drivers, what are the levers of cardiovascular health, so that we can really get to this point where we have interventions that are effective and that are tailored to the needs and the desires really of the population at risk. And I think we have a great shot at really achieving our goal of promoting and preserving cardiovascular health through childhood. And that's really our goal, is to promote cardiovascular health throughout the lifetime. So I'm going to stop there and take any questions. No one interrupted me, but hopefully you've got some questions along the way. Thank you.
So thank you for a great talk. We're all feeling a little guilty about eating our small otherwise,
I'm truly in the moderation camp that, you know, like everything in moderation. Okay.
But let me ask you, so I'm a general internist, so I tend to see adults.
Yep.
And I'm going to push you on here. No time is a lost cause. I'm often having a conversation with patients about, we have to get you to 40 years old in good shape. Because that's where people a lot of people we see feels like, and I use the phrase, go off the rails.
Well, you saw that point at 35, so that lines up with what you say. Yeah.
You know, people get busy at work.
Exactly.
Spouses are often involved, big changes in behavior, child bearing, child rearing, behaviors change a lot. But are my efforts misdirected? Would we get more? Do we know that we would get more bang to the buck by sort of preventing it in the first place, or has sorry for the mixed metaphors, not enough water kind of flowed under the bridge that, you know, if indeed a 25-year-old sort of maintains good health, bad behavior between say 15 and 25 is not so bad.
I feel like I'm going to be in trouble no matter what I say, but no. So, I'm sorry. So the question was, if you intervene, and you are thinking about, or you're treating patients who are in middle age or even in later life, is it too far gone? Like, are you going to make an impact? Are you actually going to see improvements in cardiovascular health? So yes and no. So we know that every improvement in cardiovascular health, whether it is middle age or older age, reflects a reduction in the risk for future events, so that there is no time period at which you can say, like, what's gone is gone. Like, I can't change my risk of future disease. Every intervention will reduce cardiovascular events. The amount it's able to reduce it, and whether it can restore your levels to what it would have been if you had maintained ideal cardiovascular health, is a different story. So once you start accumulating this kind of cumulative burden of cardiovascular risk, it's impossible to turn back the clock and go back to your risk that you would have had if you had maintained ideal cardiovascular health. And that's the reason we promote primordial prevention, is because if we want the biggest bang for our buck, we want the biggest effect in reducing cardiovascular disease burden later in life, we have to then intervene early and reduce the area under the curve, essentially, of cardiovascular risk factors. Now, I'm saying that globally for cardiovascular health. It is definitely true of blood pressure, of behaviors. There are some risk factors. Cholesterol, we've looked for this kind of period of no return, is kind of what we call it, beyond which if you treat, you can't restore back to ideal levels. Cholesterol looks like you can get pretty close to that, actually, but for the CVH construct, early intervention has a bigger effect size. It also is easier. And so I can imagine, you know, it is very hard to shift someone who is already acquired unhealthy behaviors, who already has elevated risk factors, who already has a busy life and is kind of entrenched in their ways. It is very difficult to make those major life shifts that need to happen in order to reflect changes in cardiovascular health. It is much easier to take someone who is already in ideal levels and promote that and help them maintain what they're already doing throughout their lifetime. So that's another burden. I think both of these and all across the life course have to happen. But from a public health perspective, if I had to put my money down, I'd intervene early and I'd try and promote the preservation of ideal levels. But that's a pipe dream. So, Ron.
I'm going to push that just
Of course,
because there's an age group in between the kids and the 35-year-old that it's related to this conversation. But you know, in primary care, where a lot of these tests actually are performed in adulthood, well, and in kids, you know, typically we wouldn't be checking cholesterol or blood sugar until somebody's 35, unless they have
elevated risk factors,
high blood pressure.
Yep.
Those really may be family history or something like that. So We won't know the essential age until they get to 35 in a lot of those folks. We would only know it if we did the additional test. So
Sure.
Is that a good strategy? Do you think you showed earlier that a lot of the higher risk in kids is driven by BMI? So like, you know, if BMI isn't increasing, it's okay just not to check those things until people are 35, or should we be doing some sort of assessment in their 20s just to sort of see the global picture of the whole age?
So what I would say is you're right. The pediatric screening guidelines wouldn't call for the measurement of many of these risk factors unless you are already at high risk. Obesity and family history would be one marker, and so those kids should be checked. The added value of measuring lipids or glucose in a normal weight or not high risk child is probably minimal. And in our work, we've shown that the vast majority of those kids are going to have normal levels. And so what's driving cardiovascular health in childhood is not generally those clinical factors for the majority of children, it's the behavioral factors. So I think that the beauty of cardiovascular health is that it can adjust to the number of risk factors that need to be measured for a child. So if a child has higher levels of the behavioral factors, so is doing well, then there's probably not an added value to measuring lipids or glucose because it's likely to be normal and to reflect those healthy behaviors. If those healthy behaviors are already starting to slip and they're reflecting in BMI, and I keep going back to BMI, we do call it this like leading indicator because it's just easy to measure. It has its new caveats, but it's easy to measure and it's easy to monitor. And it tends to be this intermediate marker between the health behaviors and the preceding the clinical outcomes. And so if you start to see drops there, then I think it does call into question kind of measuring the clinical factors as well. So I think our current strategy is okay, and it allows us to kind of measure cardiovascular health on a scale of what's relevant to each child. Does that answer?
Yeah, perfect.
Oh, sorry, Adele, I think you have one from online.
Yeah, we have a question from Zoom. So the question is, are there any efforts to develop cardiorespiratory fitness growth curves for these ages?
That's a great question. So we do have colleagues that are working on the intersection between respiratory and lung health and cardiovascular health. They are very tightly related. And that is a project that is actually ongoing now to measure respiratory health and cardiorespiratory fitness as a more quantitative marker of activity as well. We try and make sure that our cardiovascular health definition is usable. And so, cardiorespiratory fitness requires more aggressive, let's say, monitoring in terms of being more of a burden of kind of conducting the cardiorespiratory test. And so we have been using measures that are widely available. But I think fitness has been one we've looked at as to whether that would be worthwhile adding to a more objective measurement of physical activity. Kind of that. Oh, I'm sorry. I thought you had, because you had the monitor. Sorry. Did somebody else have a question? Yeah.
So when I go back to, you hit the primordial prevention theme several times. What is your message, Nori, for our obstetrician colleagues who provide prenatal, perinatal?
I think the critical piece of this is that cardiovascular health during pregnancy is important. Sorry. Apologize. Let me repeat the question so I can get it on video. So what's the message to our obstetrician colleagues about cardiovascular health during pregnancy? So one, it's intimately tied with the mother's own cardiovascular health later in life. So that's a critical reason. And two, it's intimately tied with the child's cardiovascular health later in life. So it is a period which often actually is an intervenable period during which women are particularly motivated to promote the health of their infant. And it often is, unfortunately, the accumulation of often excess gestational weight gain and poor behaviors. And so I think we really need to identify interventions during that period What those interventions are, I think still remains to be a little unclear in terms of it's a period where people are motivated, but it's also a period of intense kind of stress. And especially after the birth, then you've got a lot of competing demands that are hard to maintain. So I think that's an area ripe for understanding how best do we help women promote cardiovascular health. And one is just monitoring it, because frankly, often when they move from obstetrical care to after pregnancy, they kind of lose connection clinically in terms of measuring and monitoring their cardiovascular health. Gives you an answer. Yep.
Another question for you, Norrina.
Yep.
You said that it was, you pointed out that it's difficult to assess diet, particularly in young kids. There's no like gold standard for that. Yet you're doing it pragmatically in your current study.
Yeah.
My question is, how are you doing it, and how did you decide on how you would collect dietary information for young kids?
That's a very good question. So we have a brief diet report. So we are recommending in general for kids and adults to collect it using the MIPA, which is a brief way of assessing a Mediterranean style diet. I think it's 10 to 15 questions. So it's, you know, it's quick and easy to administer. In infancy and very early childhood, we think about other markers that have been associated with cardiovascular risk. So breastfeeding, which is a little bit controversial. I think we're still learning about how and why it influences long-term cardiovascular health, but that's one way of assessing diet quality. And then introduction of solids as well has been shown to be associated with long-term cardiovascular health in children. So those are kind of the diet assessments. I think the Young Heart study will provide us some insight as to how well those are correlated with later childhood and adolescent diet as they kind of go through life as well. So anyways. Any other questions?
Thank you so much, Dr. Allen. I feel embarrassed. I neglected to say that Dr. Allen is the director for our Center for Epidemiology and Population Health, which is a school-wide center in IPHAM. So if you have further questions, that's where you find her on our website, or you can find her on the Kleinberg registry. But thank you so much today.
Thanks, Aaron. Thank you all. Feel free to contact me if you have any other questions. Have a great day, everyone.